And I warned the parents, I'm like, she's going to get very sick, because for years she had no immune system. And she had all these bacteria that were swimming around in her blood, swimming in her system and eating her away. I said, the minute I give her back her immune system with these drugs, she's going to get super sick, because the immune system is going to turn around and start attacking every organ in her body that had a bacterium in it. And that's exactly what happened. Within 2 weeks, she had fever to 40 degrees and she was sick like a dog. And we gave her steroids because, it's like, okay, too much immunity now. Let's bring down your immune system. So we were playing, and her virus became undetectable within 2 months. Within one month, became undetectable. Her white count went up. Within 2 weeks, she started to show signs that the white count was going up. And we persevered. And I remember I said, don't stop. And we had her on steroids. At one point, my colleagues even removed the steroids, like, it's enough steroids, Chris. And I said, no, it's not. Anyway, so they removed them, and then she became quite ill again with super high fevers. And she came into the ICU seizing because she was dehydrated, because she was taking her pills, but didn't want to eat or drink anything. And we restarted the steroids, and for another 6 months, she was on steroids, and eventually everything calmed down, and she is now 24 years old.
Wow.
She was the first kid in the world, that I know of to be put on this cocktail of medication, because they weren't even approved yet.
Welcome to another episode of Just Us Dads. Thank you so much for tuning in to another Dadversation. George isn't with us today, but we do have a very special guest, and we're going to get into some interesting conversation. We're welcoming Dr. Christos Karatzios. Chris, of course, is here as well. Gentlemen, how is everything?
Very well, thank you.
Super. Chris, doctor, this is the first time that it's confusing, because usually there's two Georges here. So now we have two Chris's. So.
We'll go with Dr. Karatzios and Chris. It'll be simple like that.
Yeah.
But it's a great name. Like I mentioned before, it's a great name. I think it's perfect. Good for you.
That's right. You can call him Chris, and you can call me Doc.
Exactly. Okay, no problem.
There you go.
Thank you for taking the time. We know that you are an exceptionally busy person. And before we get started, I think we owe it to you just to thank you for everything you're doing, because you're like literally at the front lines during this whole pandemic. This entire year must have been just one crazy experience for you.
It has been. I mean, I'm an infectious diseases specialist, but the saving grace for me is that I'm a pediatric infectious diseases specialist. And thank goodness that we haven't, that children aren't as badly affected with COVID as my colleagues on the adult side are. They have been hit with a ton of bricks. Okay, I was hit with a ton of rocks. It's not bricks, because we do see kids that are sick as well. And, we've had to change our whole lives around in the hospital, and, everything just because I'm not an adult doctor, I still have to keep on top of the literature, on the vaccination literature, on everything that's been going on. I teach university. So, I had to be there right in the front from the beginning, and, helping out, and of course, being Greek and being in the community, warning the community leaders. I remember last year this time, it was very interesting, me being on the phone with the Quebec Hellenic Congress, the Hellenic community of Montreal, the Socrates schools. I even had a nice phone call discussion with the Archbishop right before the big lockdown.
But at the same time, because we had spoken last time when you were on my other pod, the children's was also modified to accommodate COVID patients as well. So you're like really smack in the middle of it, even though you're not directly impacted because there's not too many children. You're still living that whole situation.
of course, it's so weird to round in an intensive care unit and you've got like a baby, and then the next bed is like a 70-something-year-old lady with a stroke, who doesn't have COVID, but was, brought over from the Royal Vic because the Royal Vic was up to here with COVID patients. So they needed some of the non-COVID patients. So it's very bizarre to round on somebody, like that.
How is it like a year later now? I mean, how the hospitals there's less hospitalizations from what we're being told. I mean, do you feel a little less weight on your shoulders?
Yeah. Definitely. Right now we're in a lull because we're at the bottom end of the curve, the bottom end of the second wave. The fear is that it's going to start doing this, and it has started to do this in Canada. You've seen it in various European countries. It's like this now. In Greece, it's like this now. In Italy, it's like this, and they just went into into another full lockdown. We're okay. The other thing that saved us this year is that there was no flu.
Yeah.
There were no respiratory viruses that were circulating around. Only COVID and some flu and some rhinovirus. Very few other respiratory viruses, and influenza. I was shocked to see that it just went away practically, and there was no community spread of influenza.
Yeah.
That helped us because we see a lot of children during this time. My goodness, at any other year, it would be the ICUs and the wards would be full of kids with complications from the flu, pneumonias and other respiratory viruses like respiratory syncytial virus, parainfluenza virus. We just didn't see any of that.
Do you think this?
Doug, just a question from my end. Do you think that's because people are more careful? Obviously, there's distancing and everyone's washing their hands and people are wearing the mask. But do you also think that it may be because we're not looking for it or we're not diagnosing it?
Oh, no, we are looking for it. Maybe Quebec, not as much as last year, but the rest of Canada. In fact, if you look at Flu Watch, the Public Health Agency of Canada publishes a nice website. It's called Flu Watch, and it breaks it down by week. Of the year, how many cases have been identified, how many tests were done. We're doing just as many, and if not a little bit more when compared to last year, this year. So we are looking for it. It's just not there. And you asked the question why. I would say that the number one reason is the social distancing, the masks, and the washing hands. That's number one. Number two, there's something scientifically called viral interference, where there are certain viruses that, when present at large amounts in a population, trigger what's called interferons. If you get infected with COVID, you get interferons that are released in your body that last for a while. So other viruses just can't attack you and can't cause disease because you got these proteins that are naturally released in a viral infection called interferons, and they interfere with infection from other viruses. But it's not the full story. I don't buy that also. There's something else that is interesting. I think that what we're seeing in the beginning of the fall and sort of into the winter, before the variants came and messed it all up, I think we were seeing a lot of airborne transmission. This is, especially in younger adults who are gathering in houses before the restaurants and the bars closed, in bars and in restaurants. And a lot of COVID transmission can be traced back to just speaking and talking loudly. And it's not just droplet and contact. In fact, when you wear a mask, you're stopping most of these aerosols, but some do disappear and some do disperse into the air around you. And especially if you are with somebody in a closed space that's not well aerated or ventilated for a long period of time, transmission can occur, like a house, for instance. And so, in the first wave and the second wave, we didn't see a lot of children transmitting in schools because likely children don't transmit very easily an aerosol because they're short. Young kids are short. They don't have that capacity. Tuberculosis, which is an airborne mediated disease, is not very easily transmitted by young kids too. So, what we were seeing up until now was the fact that we were washing hands. So we eliminated all the droplet contact kind of spread, washing hands, wearing masks, distancing. Sure, viral interference may play a role, but also what we were only seeing was probably airborne transmission. And we weren't seeing it in schools very much because kids don't transmit very easily. The new variants, though, they're a problem because they are probably more sturdy. They are probably more transmissible, as we know, 50 to 60% more transmissible. And if they, are very easily transmitted even by a few aerosols, we will see them in schools. And this is what we are seeing now. A lot of schools, lots of these variants were being seen in schools. Hence, the reason why the government recommended finally to put masks on younger kids 5 years and older. Right. See, the public doesn't realize, but these are the thinking processes that happen at the government level.
Right. I read the other day that the Ontario Health Organization announced the third wave. You think it's going to be?
Yeah.
You think it's going to come?
Yeah, they are. In Quebec, the R number, the reproductive number that they're talking about, every virus, every infectious disease has an R number, which means like an R naught is the potential number of people that can be affected with after one person gets the disease. So the R naught for this virus potentially is like 2, 3, maybe even 5 if left unchecked. And then this R number changes once you start doing mitigation strategies. So if we wash our hands and distance and wear masks and all this kind of stuff, and lockdown, we're able to bring the R number down below 1, which stops the transmission, which means that it's not an epidemic anymore. Or it's not a pandemic anymore. The R number crept above 1 in Quebec this week. So we're starting to worry that we are at the beginning of a third wave. Wow. And Ontario is, everybody was saying, well, Quebec is the only place in North America that doesn't have a lockdown, that doesn't have a curfew. Why? And, the numbers are down everywhere, Ontario, you couldn't leave your house in Toronto, without, there was a stay-at-home order, even though there was no curfew at night.
And the schools were closed also longer.
And the schools were closed also longer, etc. What saved us, in fact, in Quebec from seeing this earlier is, in fact, the curfew, because who is spreading it? It's spreading. The younger people are spreading it. They're getting together. They're having parties. They're going to people's houses and whatever. People say, oh, what, the virus doesn't spread after 8 o'clock? Yeah, it does. But if you prevent people from going to other people's houses, you're going to prevent the spread of the virus. So, we're starting to see that our numbers start to creep up, and it could be because of the schools. We'll have to see what happens.
Tell me, let's talk a little bit about just in general, you as a doctor in that profession, and especially during this whole year, because this is a dad show, obviously. The whole work-life balance. I mean, it's hard to begin with just normally being a doctor, the irregular schedule, the long hours and all that sort of thing. And then you add to that this whole year of just craziness. How is that at home? Like you as a dad and as a family man?
I mean, I have a very understanding wife where she allows me to go down into the basement and do these podcasts instead of hanging out with her upstairs.
Thanks. We appreciate it.
Yeah. But that's why I'm like, oh, guys, can we do half an hour instead of... but no, she's understanding. I sat down with her about January or February of last year, and I said, we're going into a very, even though nobody else knows yet, I'm telling you, we're going to go into a very rough few months, the next coming months. I made her watch the movie Contagion so she can understand. If you haven't seen that movie, I would highly recommend it. It's like almost prophetic as to what happens. It's not. It's like a thriller that deals with a global pandemic with an R naught virus of 3, but a 40% mortality rate. So, but you should. It's exactly what we are living, and it's like just fascinating. So I told her, watch this, because we're going to go through this. She's like, you're scaring me. I'm like, no, watch this. And this is, and so she understands my role in this. My work balance, I mean, listen, I've got 2 young toddlers that my wife is a stay-at-home mom for now. And that has saved us because, God forbid, I have to go pick up my kid from daycare, and I got to, this, that. So I've left that part to my wife. But when I come home, I roll up my sleeves and I'm there giving baths, giving this, trying to, put the kids to bed, hence asking George to do the podcast at 8 to 8:30 to help me put down my kids, because they miss me too. So it's been rough. I mean, in the beginning, I had heart palpitations last year where I've had skipped beats. I would sit there, I'm like, oh my God, I said, I just missed another beat and another one and another one. It was happening every three beats where I would miss a beat and then my heart would go boom. And that was probably because of nerves and because of I wasn't sleeping very well, and picking up the fact that I had to deal with 225 university students that I had to teach online. So, because I teach infectious diseases at McGill University, first year medical class, and I'm responsible for the whole course, the coordinator of that course. So I knew that was happening. So I remember emailing the university in February. I'm like, have you guys thought of what to do? Because I think universities are going to close. And they're like, no. I'm like, yes. So thank goodness, though, that lectures are recorded. So I gave all my teachers who teach my course, because they're infectious diseases specialists and they were like up to here, I gave them the year off. I said, listen, we'll just play last year's recordings and I will do the live like this, right? I'll do 1 or 2, 3 times a week where I would get on and ask students, tell me what questions you have. And I did teach live my classes, but the rest of it was all from last year's recordings. And, we're going into the same, I'm starting teaching in about a month, and, we're similar kind of situation, less recordings from the year before, but still it's a logistical nightmare,
Was there any fear, like, for example, knowing that, okay, I'm going home now, I just hope I don't have anything?
Yes.
I mean, how was all that, like, in your
Yes. Yes, in the beginning, yes, because I was also saved by the fact that before we went into lockdown and during that first wave in March, April, I was teaching university. When I teach university, I don't do any clinical work because I'm there every day. Even though I'm not the one giving the lecture that day, I'm there listening to what the teacher is teaching my students. I sit in the back and I see how many kids, how many students are on Facebook and on Instagram and whatever. But yeah, so I had no clinical responsibilities. So I didn't see any patients in March, right? And then schools closed and kids didn't get sick from it. But what happened was I had colleagues who were quarantining because they had come back from spring break, or they had symptoms of something that they had to quarantine for 2 weeks. So I would take their clinics, I would do their wards. So even though that those 2 months were not clinical heavy, I did do clinics and sporadic calls here and there. And yeah, I was afraid that I would come home. There were times where, I would come home and the door to the foyer was closed. So my wife had left out all the Sterigels, and I would clean my hands and I would take off my coat and I would take off my shirt and, bring it down into the wash. I don't do that anymore.
Yeah.
Because COVID does not spread that way.
It's crazy. It's crazy to think how your life can change, especially for someone like you who's like really smack in the middle of everything, right?
Yeah. I mean, we had it all planned out that, for instance, if I was even now, although I'm vaccinated now, I have my first vaccine was given January 21st. So I probably have a good level of immunity right now. But we have it all planned out. If one of us gets sick, there's the basement. This couch back here is nice and pretty to look at. My wife hates it, but nice and pretty to look at. But we pull it out, and it's a bed, and there's a bathroom right above the stairs over here. And if needs be, a tray of food to be brought down to the stairs over here, and this bathroom here being used instead of upstairs, we will use it. I don't know where I'll shower, but
it's like a little mini man cave. So
it is.
It could be a good thing too.
It is. I've got my big screen TV right here.
There you go.
I've got my surround sound. I've got my bar. Chris, I just probably won't be able to shower.
Chris wanted to talk a little bit about your TEDx talk. Chris.
A couple of years ago.
It was a TEDx, I think Laval, I think it was called, and it was a very interesting story. So I don't want to say anything about it. I'd like you to take a moment and share that story because I thought it was very, very interesting. Yeah, go ahead.
Yeah, no, I'm an HIV specialist. That's my specialty. So pediatric infectious diseases with a subspecialty or super specialty, if you want to call it, a pediatric HIV. And I've had some difficult cases, and one of the TED talk that I described about was this girl who had AIDS. She was dying. This was back in 2005, and she was dying for a while. I mean, she had AIDS. She had multi-resistant virus. She wasn't taking her meds well when she was a kid, so she burned through a lot of her HIV drugs. Her mother is still alive. Her mother was at the time illiterate. So, even though we would write prescriptions, we'd give her the prescription, she didn't know. And so when we figured out that she was giving the medications all wrong, we color coordinated everything. But by that point, she had burnt those drugs because the virus became resistant. Anyway, and she had this other organism called atypical mycobacterium or Mycobacterium avium intracellulare, which is a cousin of TB. And basically it's called wasting syndrome or Slim disease or wasting syndrome. And it's exactly that. You waste away. And she had fevers and stuff like that. And even that was multi-resistant. So by that time I had left for Miami to do a year of HIV specialty training in Miami at Jackson Memorial. And this girl, when I was gone, had told my colleagues that she doesn't want to live anymore, 12 years old. And she said, I'm stopping all my meds. I just want to die, right? So palliative. And so they were discussing about letting her pass away. And when I was in Miami, I ran into a pharmaceutical representative who was talking about a new drug. Johnson & Johnson actually is Tibotec is a Johnson & Johnson, Janssen, and then Tibotec. They're all one company. They were coming up with this new drug that was good for multi-resistant HIV. And so I remembered that when I came home and my colleague said, how's our favorite patient? They're like, oh, she's going to die. We decided that just, put palliative care for her. I'm like, what? No, hell no. I'm not going to do this, I said. So I emailed that person and they put me in touch with the head of the division here in Quebec. And not only did that company come through to give me, I asked for exceptional circumstance, like, a compassionate release. There were studies in kids, but they hadn't been published yet. And they were just doing the studies. And not only did they give me for free, this girl, that drug, but also a second drug that was on the pipeline. So I had two. I'm like, oh, yes. Two drugs against HIV so I threw those both at her. We put a hole in through her stomach, like a G-tube, so she doesn't have to take them, and parents would pop them and I warned the parents, I'm like, she's going to get very sick because for years she had no immune system. And she had all these bacteria that were swimming around in her blood, swimming in her system and eating her away. I said, the minute I give her back her immune system with these drugs, she's going to get super sick because the immune system is going to turn around and start attacking every organ in her body that had a bacterium in it. And that's exactly what happened. Within 2 weeks, she had fever to 40 degrees, and she was sick like a dog, and and we gave her steroids because it was like, okay, too much immunity now, let's bring down your immune system. So we were playing, and her virus became undetectable within 2 months. No, within one month became undetectable. Her white count went up. Within 2 weeks, she started to show signs that the white count was going up, and we persevered. And I remember I said, don't stop. And we had her on steroids. At one point, my colleagues even removed the steroids, like, it's enough steroids, Chris. And I said, no, it's not. Anyway, so they removed them, and then she became quite ill again with super high fevers. And she came into the ICU seizing because she was dehydrated, because she was taking her pills, but didn't want to eat or drink anything. And we restarted the steroids, and for another 6 months, she was on steroids, and eventually everything calmed down, and she is now 24 years old.
Wow.
She was the first kid in the world that I know of to be put on this cocktail of medication, because they weren't even approved yet. Now everybody's using them, but I remember writing it up and sending it to a conference. It's called CROI. It's the big North American HIV conference, and they refused it because they said it's one case, so we can't make heads or tails out of it.
Right.
So I lost after that. I didn't have time, and I lost the interest to, write it again and again and again. So that's the story, and that's my TED Talk story.
So that's a great story, and I remember you concluded that TED Talk with saying that's why you're a doctor. That was actually the whole, and great reason, great purpose, and that keeps you going, definitely, right?
Oh, for sure.
I had a little follow-up question. We know that, look, you're an AIDS specialist. We know that, I don't know, correct me if my stats are off, but 38 to 40 million cases, I think, around the world.
Yeah.
I think it's 1 out of 4 in Africa. So obviously Africa is a little bit more.
Depends on the country. Depends on the country.
Okay.
You have some countries like Lesotho and Lesotho, Botswana, Eswatini, it's called now. They have huge amount, like 40% of the population.
Wow.
Yeah.
So my question is that, so obviously, some countries in Africa, you see it more. I guess it's more common there. What is the situation here? Because I think in 70s, 80s, you would hear a lot of it, and then it kind of died down. Like it's not something people worry. Well, at least we don't hear people worry about it too much. What's the story here with AIDS? Yeah.
So in Canada, we have about, if I'm not mistaken, the last numbers I checked, about 30,000 that are living with HIV. About 1,000 kids across Canada, 2,000 children, something.
Which is not a full-blown AIDS, right? It's still the virus, right?
Right. Okay. Very few people have full-blown AIDS in Canada because we have good drugs and we have good healthcare system, and people. It's not like before in the 80s where we had like 3, 4, 5 drugs. Now we've got upwards of 20 drugs that are, and some of them, the newer ones on the pipeline, my God, they just got approved in Canada. One shot, it lasts you for like a month, and you just go back and you get another shot. So you don't have to worry about, not taking your pills and having a resistant virus grow out of you because you're not taking your pills properly.
Where are we with the early?
The situation is great, where we've been able to practically stop mother-to-child transmission, pregnancy. Before it was like 30, 40%. Now it's like, 1-0%. I know people don't like absolutes, so the number is, maybe less than 2%, we say, but it's really closer to 0.
Yeah.
How where are we with the early detection? Because I mean, you don't just wake up one day and say, "Let me just go get tested for HIV." Or where are we with that? What are the symptoms and how late do they come before it's too late?
That's the thing, right? HIV is like the big imitator and the silent imitator, because you could be. It all depends on how good your immune system is to start with. HIV destroys your immune system. If it destroys it fast and you get a weird infection or a cancer, or you get tuberculosis, then every person who has got TB is screened for HIV, because these two love each other. But if you get a weird infection, they test you for HIV. If you get like a weird cancer, they'll test you for HIV. It all depends how quickly your immune system gets destroyed. Some people genetically, and it could be the virus, a more virulent strain, and it could be your genetics, or it could be an interplay of the two. Some people can be what's called elite controllers, where they're immune. Well, they're not immune, but they have HIV. They've been exposed to it, and they just you don't measure it in their blood. And it's probably because they have some kind of mutation that allows the virus to die off, and they're immune to it. There are others who are called long-term non-progressors, and again, they don't progress. And then there are other ones that progress. Most people do progress, though. And the detection. I mean, listen, there's always, if you stick yourself with a needle, if you have unprotected sex, if you have this, if you have that, then yeah, you go and you get tested. And the window period used to be 3 months, right? They say, we can't measure your antibodies for 3 months. But with the new tests that we have, we've been able to bring down the window period to about 2 weeks.
Okay.
Quebec, their testing brings down their window period to about 7 days.
Is there more being done for HIV awareness and early testing, or is that not in the health priorities here in Canada?
So the health priorities now, obviously, is COVID, but for years we've been, why is there a World AIDS Day on December 1st? There's a World AIDS Day so awareness can continue, because what we were seeing, out of sight, out of mind, means I can do, I don't think about it, so I'm going to have unprotected sex. I'm going to have multiple sexual partners and not wear a condom. In the men who have sex with men population, there was a big explosion in various sexually transmitted illnesses in bathhouses, and out of sight, out of mind. And look at how many teenagers are having unprotected sexual intercourse, and not only intercourse. I mean, oral sex and all this. Not everything is 100% safe.
Mm-hmm.
If they're not reminding people about it, then they'll forget.
And a question. This is I remember at the time it was very controversial, like the origin of AIDS, right?
Yeah.
There was uncertainty. There was a debate about it. It was a little bit controversial. Do we know more today?
We have an idea. Yes, there's a very great book that you should read if you can find it on Amazon. It's called The Origins of AIDS, and it's written by Jacques Pepin, not the cook, Jacques Pepin, not the French cook, but the chef, but he's an infectious diseases doctor in Sherbrooke, and it's a very interesting story how this whole thing happened. We believe that the first leap from chimpanzee to human happened sometime between 1911 and 1918.
Okay, so that's, yeah.
And it happened somewhere in sub-Saharan Africa, near Uganda, sort of like on the western tip of Africa, western tip of the sub-Saharan Africa. And probably from bushmeat. You don't know what bushmeat means. It's basically chimpanzee meat, and hunting and cutting down the chimpanzee and getting contact with the blood. And chimpanzees have two viruses that one is called simian immunodeficiency virus, which causes AIDS in chimpanzees, and they also carry human immunodeficiency virus, the cousin, which causes nothing. It's the reverse with us. HIV causes AIDS with us. SIV, simian immunodeficiency virus, does not cause anything with us. So anyway, so there was this interplay, and somebody got infected, and it was local. It stayed local in the villages, in the remote villages, whatever. He had, whoever this person was, may or may not have transmitted it to his wife and to his mistress or whoever. And but it stayed local. That's the important thing. And throughout the years, white man came in. WHO, all these other, non-governmental organizations that said, we got to, stop syphilis from spreading, or stop this from that happening. So they had vaccination programs, or syphilis, penicillin injection programs, where they would go into a village, they would diagnose, I don't know, out of 200 people, they would diagnose 100 people with syphilis, but it wasn't really syphilis. It was Yaws, which was the cousin of syphilis, but the test couldn't tell the difference. And they would give, penicillin shots to everybody, one needle, right? Nobody knew about this.
Mm.
They thought they were doing well, but they were spreading it. With the advent of industrialization in the sub-Saharan African continent, and the industry went from larger villages became bigger towns, and whenever there's industry, there's prostitution, and so this was all. And then it just became a bigger problem, an epidemic in Africa. And then what happened was Haiti. Haiti was a big gay-friendly tourist area in the 70s. And so a lot of North Americans and Europeans would go to Haiti, to the resorts there, because there was, it was a gay free-for-all. And there were a lot of migrant workers from Africa that mingled with the local Haitian population and infected the local Haitian population. And then those population, maybe many of them were men who have sex with men, who obviously had sex with tourists, and then they brought it back to their there was a whole interesting idea. If you remember the Air Canada flight attendant who he infected, one man infected 200 people. He is thought to have been patient zero in North America. It's probably not true. I think there were many patient zeros that happened. And then it just exploded in the 70s and in the early 80s. And that's when people started to realize that's what HIV is all about. And so that's the whole origins of HIV.
All right, thanks. Wanted to know. This was a personal question. It's just me that wanted to know. It wasn't for the audience, this one.
I would buy that book if I were you.
Sure.
Very interesting book. The Origins of AIDS. If you can find it on Amazon still.
We don't want to take up too much of your time. We know that you want to get to your family. Just wanted to talk a little bit because this is a dad show or a family-oriented show, we wanted to touch a little bit about the common diseases or conditions that that are in children, for example. What do you see more often, or what's happening in our hospitals? How should families be careful or be worried? And how do they, the solutions, or how do they kind of overcome them?
So, right now, or in general?
In general, the common stuff that you see.
No, common things are common. Viral infections,
Okay.
Right? Vaccinate your kids. Make sure that they know how to wash their hands. Make sure to teach them hand hygiene and not to spread germs. And bioterrorist camps called daycares, the children are bioterrorists, but what we've been seeing the last year is, and especially now with after the second wave, is this post-COVID multi-inflammatory syndrome that looks like Kawasaki disease. You may have
heard about that.
Where they come in, with severe abdominal pain about a month after having COVID, with high fever, severe abdominal pain, then they have cardiac crash, right? They may have red eyes, cracked lips, a rash, all of that. So I would tell parents that, even after a mild COVID case, or even after an asymptomatic COVID case, they come in quite sick and they need ICU. And so what I would tell parents is that if your child suddenly starts to have severe abdominal pain and fever out of nowhere, there's no gastro going around right now. Okay, because everybody's washing our hands and we're all wearing masks and stuff. There's no gastros. So think that this could be something more serious, that your kid may have had an asymptomatic COVID infection about a month prior. Or maybe they didn't, maybe you knew, right? Or maybe there were cases in the school that were COVID positive and your child never got tested because they went to quarantine and they never felt sick and blah, blah, blah. If that kid develops red eyes, cracked lips, red rash, or fever, high fever with abdominal pain and vomiting, you bring them into the hospital immediately. That's one thing that I can say right now. What we're dealing.
And the main criteria for that is COVID. I mean,
the main criteria for that is COVID. They are not infectious at the time. They're COVID negative when they do the test. But when you do the antibodies, you may find the antibodies. So the story is still, my team. I was part of a team that published guidelines for physicians to understand this, and it was just published on February 25th in the journal Vaccine. So, I'm one of the only 2 Canadians that are on there, and the only one from McGill that has contributed to that. So it's basically an algorithm for doctors to follow to diagnose this illness, because it's a clinical diagnosis.
Okay.
So that's number one. I'm proud of that. That's number one. Number two, what we're seeing is, in general, we're seeing a lot of kids that used to die in the past that are surviving. So we're talking because of technology. So I'm talking about the extreme prematures and the extreme, the genetic disorders that, in the past they wouldn't survive because we didn't have the technology or the medications to have that. But now, we're seeing kids who were born 4 months premature, and they've got chronic lung problems and chronic eye problems and chronic mobility problems, but they are still alive. And so we're seeing a lot of those kids who would be in the neonatal intensive care unit are now living in, graduating out of the neonatal intensive care unit, but coming in with other chronic symptoms. And a lot of our floors have a lot of these chronic type, very complex patients.
Right. And this, what age bracket are we talking about? We're talking about in the earlier years after, or?
Yeah. We're talking about anywhere from the kid is just born and just got out of the NICU and is a few months old, to their home, but they're home on home oxygen. They've got feeding tubes. They've got and all the complex problems that come with that. And so they come in with a pneumonia, or they come in with the flu, or they in the past, not this year, and then they come in with whatever, right, dehydration or a seizure that they had at home, etc. So we have to deal with that. There was a lot of that in inpatient pediatrics right now. The classic, urinary tract infections, pneumonias, this and that, yeah, they come in, but and we treat them, and that's it. But we see a lot of chronic patients as well.
Yeah, but for those, what are the chances of survival now? And
They survive. It's just, the thing is that how do you tell a parent who needed in vitro fertilization, for instance, and they had a very premature kid, and the mother is in her 30s or in her 40s, and she can't have kids anymore, and she really wants this kid to live. The thing is that a lot of these parents hang on to the positive of their child, and they don't see, or they do see, but all the difficulty that this child and the a lot of them have poor quality of life as well. Mm-hmm. So it's very touchy, but we do approach some parents and say, listen, what do you want us to do if your child deteriorates to the point where we need to put him back on a ventilator? What do you want to do? So we do have a lot of these difficult talks with parents.
Yeah. That must be tough.
Yeah, it is.
One, and I don't know how specialized or how much knowledge you have of this, but there's one thing that seems to be much more current now than it was in the past, and that's autism.
Yeah.
There's a lot of arguments suggesting that, the vaccines that are given to the kids early on, like the 1 or 2 year old vaccines there's some arguments that link autism to that. But why are we seeing more cases of children in the spectrum of autism?
So number one, I just have to say, there is no link. Okay. The stuff between vaccine or MMR and autism is flawed. The person who Andrew Wakefield, the person who came up with this theory back in the 90s, did a lot of damage. He fudged his results. In fact, they withdrew his paper, and he's lost his medical license, and now he's in the world of anti-vaxxers. There is no link. There's been multiple studies that have been done with vaccines, and they have absolutely no link with that. It's the reason why we're seeing a lot more is because we're recognizing a lot more. In the past, autism used to be, Rain Man, but now we're seeing
the spectrum.
You're seeing a kid with who's not as socially comfortable as he's on the spectrum, or a kid with learning difficulties, he's on the spectrum. So there's a lot of that's happening around the world. There's genetic issues as well. A lot of these kids have somebody else in the family that has some kind of neurological disease as well. There is a nice theory that paternal age may play people are delaying having their first child now as they put their careers, et cetera, first, and then they get married and have kids. There seems to be some correlation with advanced paternal age above 45.
Okay.
That is linked to that. So there could be some genetic issue there. Who knows what else we've been exposed to in our environment that may be affecting everybody's genetic makeup.
Right. There's a lot of research though, and we seem to have made a long progress with that. I read recently there's a whole project now to create a huge center here in Montreal for.
Yes, I heard.
50 million.
Yeah. A lot of great stuff happening. Chris, we don't want to take up too much of your time. We know that you want to get back to your family. Thank you so very much for doing this. Your time is always appreciated.
Absolutely.
For everyone watching or listening, if this is the first time you're on the show, head on over to YouTube, subscribe, like, and follow us on all the social media and audio platforms as well. Chris, once again, thank you so much. Have a good night, and thank you all for listening. We will see you.
Thank you, guys. Thanks for the opportunity. Have a nice night.
Thank you, doctor. Thank you.
Ciao, Chris.
Bye.
Bye.